Welcome back to the deep dive. Today we're tackling something huge, actually the largest organ system in your body, the integumentary system.
Yeah, it sounds fancy, but it's basically your skin, hair, and nails.
Exactly. And most people probably think of skin as just, a covering, but it's so much more than that.
Oh, absolutely.
Yeah.
It's incredibly dynamic. It's a shield, yes, but also a sensor, constantly reading the environment.
And it kind of keeps a log, doesn't it, of your overall health?
It really does.
Yeah.
It's like a visible record book. And our mission today really is to help you understand its structure and function.
And crucially, how experts read that logbook, those little signs on the surface.
Right. We want to give you the shortcuts, the key things to look for, so you know what your skin might be telling you about what's going on deeper inside.
Okay, sounds good. Let's start with the basics, the structure. You mentioned the three parts, skin, hair, and nails. But the skin itself,
Right.
it's layered, right? Like a really well-built wall.
That's a great analogy. It's mainly two layers, the epidermis on top and the dermis underneath.
So the epidermis is the outer bit.
Yes, the outer, highly differentiated layer. Deep down, its basal cell layer is always making new skin cells.
But the very top layer, the one we touch.
That's actually made of dead, keratinized cells. It's tough. It's our first line of defense, sort of the sacrificial shield.
Okay, armor layer. Got it. What about the dermis beneath that? What's its job?
The dermis is all about support and elasticity.
Yeah.
It's mostly connective tissue, think collagen for strength, and elastic tissue for that snapback quality.
Ah, so that's why it's stretchy but strong.
Precisely. And then beneath that, there's the subcutaneous layer, which is mostly adipose tissue, fat, basically, padding.
Okay, structure makes sense.
Yeah.
Epidermis, dermis, subcutaneous. Now, what does this whole system do all day beyond just sitting there?
Oh, it's incredibly busy. Function-wise, first, it's waterproof and protective, keeps the bad stuff out, like microbes.
Right, the barrier function.
Definitely. But it's also a key regulator. Temperature is a big one, shivering when you're cold, sweating when you're hot.
And it feels things, obviously.
Absolutely. Sensory perception is huge. Temperature, touch, pain. It's constantly feeding information back to your brain.
Wow. And internally, I heard something about vitamin D.
Yes. It plays a crucial role in synthesizing vitamin D when exposed to sunlight. And it even helps excrete some waste products. It's a powerhouse.
A self-regulating powerhouse. Okay, I like that.
It really is adaptive.
Which makes total sense why changes on the skin can be like an early warning system for other problems.
Exactly. That's why gathering the health history is so vital before you even start the physical examination.
Because what you see might be linked to something else entirely.
Precisely. So in a review of systems, we ask about everything. Family history of skin issues, medical history, lifestyle, allergies, what skincare products you use.
And specifics about the skin itself.
Oh, yeah. Any changes in color, texture, new moles or lesions, rashes, we cover all of that.
And if someone comes in with, say, a specific rash that just popped up, how do you drill down on that?
That's where a mnemonic like OPQRST comes in super handy.
Yeah.
It's like a detective's checklist for symptoms.
Okay, break that down for us.
O is for onset. Simple question. When did it start? Provokes or palliates. What makes it worse? What makes it feel better? Heat, cold, scratching, lotions.
Q is quality, right? What does it feel like?
Yes.
Yes.
Is it itchy, burning, stinging, throbbing? Getting that description is key. Radiates a region. Where is it exactly?
Yeah.
Does the feeling spread anywhere else?
S is severity, like on a scale.
Yeah. Or how much does it bother you? Does it keep you up at night? Affect your daily activities?
And finally, T.
Timing. Has it changed over time? Is it constant or does it come and go? Worse in the morning or evening?
Wow, okay. OPQRST. That gives you a really detailed picture just from talking.
It really does. Then, for the physical assessment, you don't need much. Good lighting is crucial, though.
Gloves, obviously.
Gloves, yes. A pen light can help see details. And, importantly, a flexible ruler or tape measure.
Why the ruler specifically?
Because if you find a lesion, you have to measure it. Size matters, and we use centimeters for consistency.
Got it. Centimeters. Okay, let's move to the hands-on part. Inspection and palpation. Where do you start?
Usually with color. Just looking at the overall skin tone. It should be fairly even and consistent, within the person's normal range.
Which varies hugely, of course. Whitish pink to dark brown.
Exactly. We're looking for unexpected findings, like areas of hyperpigmentation, darker spots, maybe sun damage, birthmarks.
Or the opposite, hypopigmentation.
Right. Lighter patches, think scars, stretch marks, or conditions like vitiligo.
But then there are the colors that signal something more systemic.
Yes, those are the big ones. Pallor or paleness can suggest anemia or shock, poor blood flow. You check less pigmented areas like lips or inside the mouth.
Okay, and redness.
That's erythema, usually means inflammation, infection, maybe sunburn, vasodilation. We often check areas prone to pressure sores.
And the really worrying ones, blue tinge.
Cyanosis. That bluish color, especially around the mouth or in the nail beds, that screams low oxygen, hypoxia, or maybe impaired blood return. Needs urgent attention.
And yellow.
Jaundice. That yellowish cast to the skin and, importantly, the sclera, the whites of the eyes. Big flag for liver problems or issues with red blood cells breaking down.
So color tells a huge story about circulation and organ function.
Instantly. After color, we gently feel the skin, usually with the back of our hand, for temperature,
Looking for?
warmth, and, importantly, that it's equal on both sides. That suggests good circulation. If it's overly hot, hypothermia, maybe infection. If it's cool, hypothermia could be poor circulation or exposure.
And texture, what can that tell you?
Normally, it should feel smooth, but sometimes. Like velvety skin can be linked to thyroid issues.
Yeah.
Roughness, dryness, we call it xerosis, often points to dehydration. Flakiness, too.
Okay. And still with palpation, we check fluid status, turgor and edema.
Right. Turgor is that elasticity test. We gently pinch the skin, usually over the clavicle is a good spot.
And if it stays pinched up?
If it tense, holds that fold for more than, say, 3 seconds, that indicates decreased turgor. Often means dehydration. But it can also just happen with advanced age as the elasticity decreases naturally.
Makes sense. And edema, swelling.
Yeah, edema is fluid accumulating in the tissues. The skin often looks shiny, taut. We assess it by pressing gently, usually over the shin or ankle, and seeing how deep an indentation it leaves and how quickly it rebounds.
There's a scale for that, isn't there?
There is a 4-point scale. +1 is just a trace, maybe 2 millimeters deep, bounces back fast.
And the other end?
+4 is severe, leaves a deep pit, maybe 8 millimeters, and it takes a long time for the skin to return to normal. That prolonged return time is really the key indicator of significant fluid issues.
Okay. What about when you see blood that's sort of leaked out under the skin, vascular lesions?
Good point. There are a few key types. Petechiae are tiny, like pinpoint red or purple dots, less than 3 millimeters, often from infection or trauma, like burst capillaries.
And a bruise.
Clinically, we call that ecchymosis, just bleeding under the skin or mucous membranes. It changes color as it heals, as you know.
And purpura.
Purpura are larger patches of bleeding, red or purple spots. Can be related to platelet problems or sometimes just fragile skin in older adults.
Got it. Okay, so that covers the general assessment. Now, what if you find a specific spot, a lesion? Part 4, you called it the vocabulary of damage.
Yeah, if there's a lesion, you need to describe it very specifically. What's its color? Is it flat or raised? Height? What's its shape? Critically, its size measured in centimeters.
Location, too, right? Where is it and how is it distributed?
Absolutely. Location and distribution pattern. And is there any exudate, any fluid coming from it? If so, what color? Any odor? And people might have heard of the ABCDEs for checking moles for melanoma. That's part of this detailed assessment, too.
So let's classify some basic lesion types. You mentioned primary lesions.
Right. Primary lesions are the ones that first appear, sort of the initial reaction. We often distinguish them by whether they're flat or raised and if they contain fluid.
Give us an example of a flat one.
A macule. Flat, you can't feel it. It's just a color change. And it's small, less than 1 centimeter. A freckle is a perfect example.
Okay, flat is a macule. What if it's raised a bit?
If it's solid, raised, maybe a bit rough, but still small, less than 1 centimeter, that's a papule. Like some types of keratosis, you can feel it's elevated.
And if it's raised and has fluid inside?
If it's small, less than 1 centimeter, and filled with clear or serious fluid, that's a vesicle. Think of a blister from herpes zoster or chickenpox.
What if the fluid is pus?
Then it becomes a pustule, still usually small, less than 1 centimeter, but filled with purulent fluid. Acne is a common example.
And what about larger, solid, raised lumps?
That takes us to a nodule. Still solid, elevated, palpable, but bigger. The definition here says greater than 1.5 centimeters. It suggests something deeper going on.
Okay, that clarifies those basic types. Now, a really serious type of tissue damage. Pressure injuries. Or ulcers.
Yes, pressure injuries are a huge concern, especially in healthcare settings. They're caused specifically by unrelieved pressure, usually over a bony prominence like the hip or heel.
And that pressure cuts off blood flow.
Exactly. It leads to ischemia, lack of oxygen, and tissue death.
Who's most at risk?
Anyone who is aging, has limited mobility, maybe is incontinent, obese, has edema, or sensory issues where they can't feel the pressure, or has impaired circulation, they're all very vulnerable.
These are staged, right? To track severity.
Yes. Staging is critical. Stage 1 is that first warning sign.
What does it look like?
Stage 1 is intact skin, but it has an area of non-blanchable redness, meaning you press on the red spot, it doesn't turn white, and then pink again. The damage is already starting under the surface.
Okay. Stage 2.
Stage 2 is partial thickness skin loss. It looks like a shallow, open ulcer, maybe like a blister that's opened. You're seeing the dermis. The wound bed is often red-pink and shiny.
Clicking deeper. Stage 3.
Stage 3 is full-thickness skin loss. You can actually see subcutaneous fat.
Yeah.
There might be some slough, that yellowish, stringy, dead tissue, or even eschar, which is hard, black, leathery, necrotic tissue. But you don't see bone or muscle yet.
And stage 4 is when you do.
Correct. Stage 4 is full-thickness loss where bone, tendon, or muscle is exposed. This is extensive damage.
You also mentioned unstageable.
Yes. Unstageable means you can't actually see the true depth of the wound because it's covered by too much slough or eschar. You know it's at least a stage 3 or 4, but you have to clean it out first to stage it properly.
And one more, DTI.
Deep tissue injury. This one's tricky. The skin might still be intact or could be non-intact, but it has this deep red, maroon, or purple discoloration. It looks like a deep bruise, signaling significant damage to the underlying tissues before it fully opens up.
Wow. Okay, wound color can also give clues, right? Red, yellow, black.
Like a quick visual cue, red generally means healthy granulation tissue, good healing. Yellow often indicates purulent drainage or slow, needs cleaning. Black means eschar, necrotic tissue, which usually needs to be removed.
Given how serious these are, prevention must be paramount. Key strategies.
Absolutely. Inspect the skin daily meticulously. Keep skin clean and dry. Use moisturizers. Ensure bed linens are smooth, no wrinkles.
And movement.
Crucial. Reposition patients in bed every 2 hours. If they're in a chair, they need to shift their weight every 15 minutes. Nutrition helps too high-protein diet for tissue repair.
And what's the one thing you should not do?
Do not massage bony prominences. People used to think it helped circulation, but we now know that friction can actually increase the risk of breakdown.
Good to know. Okay, shifting focus slightly. Let's wrap up with the accessory structures. Hair and nails. What do you look for with hair?
Color and texture, obviously, though that's often affected by hair products. But distribution is important diagnostically.
Like male or female pattern baldness.
That, yes. We use Tanner staging for developmental patterns, but also clinically. For example, a sudden lack of hair growth on the lower legs could actually indicate peripheral vascular disease, poor circulation down there.
Interesting connection. And nails.
We look at shape and contour. Normally there's a slight curve about 160 degrees at the nail base. Jagged nails might just be habit or poor care.
But clubbing is significant.
Yes, clubbed nails. Where the angle becomes greater than 160 degrees, the nail curves down like a spoon. That can be a sign of chronic low oxygen levels, often linked to lung or heart disease.
And the quick circulation check using nails?
Capillary refill. Press gently on the nail bed until it blanches, then release. The pink color should return almost instantly, definitely in less than 3 seconds. Longer than that suggests poor peripheral perfusion.
Okay. So as we pull all this together, we need to acknowledge how aging itself changes this whole system, right? Making people more vulnerable.
Definitely. It's a key factor. As people age, the skin naturally becomes thinner, more translucent, drier. It loses elasticity, so you see more wrinkling, sometimes a leathery look. It tears more easily.
Hair and nails change too.
Yep. Hair often thins on the scalp or pubic area. Nails tend to grow slower and can become thicker and more brittle.
And the biggest risk factor related to aging skin structure.
It's the loss of that subcutaneous fat layer, especially over those bony areas we talked about, hips, heels, elbows. There's less padding, less insulation. This dramatically increases the risk for skin breakdown and pressure injuries in older adults. The whole system just isn't as resilient.
It really paints a picture of how interconnected everything is. This has been a really comprehensive look at reading the integumentary system.
Yeah, from the basic layers and functions.
Right, through the OPQRST histotaking, understanding color changes like pallor or cyanosis.
To identifying specific lesions like telling a macule from a papule and understanding the seriousness of pressure injury staging.
It really underscores that the skin, hair, and nails are constantly communicating. Knowing these assessment points helps you decode that story.
It's a logbook, like you said at the start.
So let's leave our listeners with a thought. We talked about how aging makes the skin thinner, drier, less elastic, partly due to declining glandular function, less oil, less moisture.
Right, that protective barrier function gets compromised.
Okay, so if the skin's main job is to be this waterproof, protective barrier. What happens when that barrier weakens with age? Especially on our modern world. Think about, constant washing, harsh soaps, maybe environmental pollutants.
That's interesting. When a system designed to be self-lubricating and resilient becomes inherently drier and more fragile, how does it cope with an environment that might be stripping away even more of its natural defenses?
Exactly. What does that suggest about future skincare needs? Maybe moving beyond just moisturizing to actually, actively reinforcing that compromised barrier.
Yeah. What does true skin support look like when the baseline has shifted? Definitely something to think about.
Something to ponder until our next deep dive.